let's move on to our second topic, and that was about ensuring a collaborative approach between clinicians and managers, so they have a shared focus on improving quality and value and not arguing, as Anna said. And how do they get the right balance between holding managers and professionals to account but devolving responsibility? Yeah, quite a lot to get on with here.
If I can just start with a caveat, because we have a self-critique which says that we have a tendency to describe the problem, perhaps to say what should happen, but be much less clear about exactly how it's going to happen.
Right.
And I think that's the real challenge. Absolutely agreeing with what Cyril said about the importance of devolution to clinicians working with managers if they're held to account, if it's transparent, a freedom of teams within a delegated process. And the question is, why doesn't it happen everywhere? Are chief executives more risk averse these days? Do the rules get in the way? Perhaps professional rules sometimes. But in some places it does work, so maybe it would be really worthwhile trying to describe the characteristics of organisations where there is a positive culture of collaboration between different sections. And there are really good models out there, so it's not all negative. So it would be a matter of turning the question round to not say what should happen and how do we do it, but in fact this has happened and what's made it good. And I think we could look at that. There were a few suggestions. Health service managers in training tend not to talk to doctors and nurses very much, at least in their early years, so maybe that would be something to work on. But the real importance was about having a shared vision and strategy between doctors and managers working together, and really that the core vision needs to be articulated about that it is about good, compassionate care. And it's using those words about compassion and care and really articulating the business again. And it's perhaps going back to that really basic issue.
Anthony was very clear about it being a very simple focus.
Absolutely, and I think maybe we all need to start using that language.
Did you talk at all about the second bit? Admittedly, you had two questions in one there, was about this issue about holding to account for delivery and for responsibility.
We did talk a little bit about delegated responsibility to teams. Of course, in order to do that properly, you need to have data and proper support mechanisms, and often they're not there for the teams. But the question is then, if you hold to account, what happens if, who ultimately holds the responsibility, and is it then the chief executive and they get sacked again because they've allowed things to go out of control? So I don't think we came up with any huge, there's a great number of things we could have said, but we didn't talk about that. But
there are a few examples of, people call it differently, but locally managed self-determination amongst local teams, clinicians and managers. You agree what they're going to do and you agree the budget, and then you let them get on with it. And the senior management's job then is to remove the blockages in the way. The only deal is that they have to manage the business and the affairs and the service visibly, so that the whole organisation can see what they're doing. The other thing is, I think it's time that the local teams, the clinicians and the managers, did begin to agree some sensible targets. I mean, being allowed 3 deaths a year from C. diff is outrageous. There shouldn't be any. But that should be an agreement between the clinicians. They both ought to say, we won't tolerate this in our organisation, and if that causes financial problems, we'll deal with the financial problems. And that's an area where the two can work strongly together. There ain't enough of it around.
Yeah. There's a difference between a target and a continual improvement, I guess. Anthony, do you want to come in?
Yeah, just a simple thing about holding to account bit, which is not my idea. It came out of the last seminar that you hadn't realised, but we introduced the NHS Code of Conduct 10 years ago, and it's not nationally implemented, it's not obligatory, it's not mandatory. If we even tomorrow said to everybody, this is now mandatory, you've got to sign, every single healthcare individual's got to sign up to it, it would be far easier to hold every single member of the health service to account.
Absolutely. I mean, there's an NHS Code of Conduct. Cyril referenced the duties of the doctor, which I think Robert suggested might be just as...
There's no central record kept anywhere about how managers have performed under the Code of Conduct. It's all devolved to local trusts and the information's lost entirely.
What value would a central record have, if there was to be one?
If we're concerned with reflective learning and seeing what goes wrong and the patterns of what pressures people suffer, and I suppose many of these mistakes, let's call them mistakes, will happen under circumstances that are very understandable. Some are unforgivable, but we'll see the patterns and we'll learn. But I mean, unless a DH takes some interest in some root cause analysis of why these things have happened and look at in the round.
It won't be opposed by DH, it'll be opposed by providers.
What, as being another burden of regulation?
I think you're right, but I just think somebody needs to say, that's it, that's what you've got to do. I mean, 99% of the population would agree with it.
I agree.
Well, you've got two things in there. One is about the code of conduct being something that's part of your contract of employment, and the second bit is about whether there's some sort of central monitoring, and those are two separate
There's
bits.
nothing in this duties of a doctor that says I will manage my clinical practice within a budget.
Aha. There's a caveat there. Suzette, do you want to put it there?
Hi, yes, Suzette Woodward. I may have misunderstood what people were saying over there, but there absolutely is a central record. There is a national reporting and learning system which collects incidents from across the entirety of England and Wales from every care setting. And we have 3,000 incidents reported a day. They are not simply about clinical care, they're about anything that affects patients. And they're an amazing record, so we do actually have that. What we need to do is, and I probably misunderstood what you were talking about, but I just wanted to say that out loud anyway. But what we need to do is really truly understand the contributing causal factors that lead to those incidents within that system. But for me, there's a very clear answer to the second part of question 2, which is to truly understand what a just culture is, and for everyone in the NHS to truly understand that and implement it, because it's very, very simple if you get it right. And a just culture is supporting people when things go wrong, truly understanding why people violate procedures and policies, because there may be good reasons and bad, but to tackle and to call people to account for reckless behaviour, and obviously malicious intent is dealt with by the justice system. And it is a very, very clear process, the just culture, but very few people truly understand it.
And I suppose the other issue in there is holding people to account for things that they couldn't have been responsible for. The interventions have to be proportionate. Michael, did you want to comment?
Well, I just think we should just remember that the NHS is not the old nationalised industry that it seems to be conceptualised as by some of the people who've been talking about this. The NHS, a large number of NHS services are going to be provided by independent companies, some of which are not even based in this country. They're not going to be employees of the state. They're no longer answerable to the Department of Health. And I think we're trying to construct a system for what the NHS sounded like, might have been imagined to have been like in 1970.
So what should we do then, Nigel?
Well,
if we are to get some organisations
well, what do we do in other professions?
They should sign up to the same contract.
What do we do in other professions?
The same contract.
Okay.
Same
Well,
organisational
if that's the method, then that's right. But I just thought we should point out that you seem to be still conceptualising this, that the Department of Health runs hospitals. That's how we got into this situation in one way. It could be argued in the first place.
And of course we do have foundation trusts.
We have foundation trusts, but we also have increasing amounts of elective surgery provided by companies, some of which are not even UK companies. They're based overseas. So the answer to your question, I don't fully know the answer to your question. Is that a bit of humility is probably required here.
That'll be a first.
I was only going to support what the previous speaker had said, actually, in terms of holding people to account and the difference between that and encouraging people to be open. And I thought some very good examples in Patient Safety First, that publication of where the wrong approach when people have been open can really discourage that kind of openness, which is so important in terms of learning lessons.
Absolutely. You brought us on really to the third question about